Hello everyone, I'm Rachel from Physiopedia and today I'm talking to Richard Norris. Hello Richard.
Good morning, Rachel.
Thank you for joining me today. I am very excited to talk to you about complex knee injuries. I know it's an area that you have a lot of interest in and you do a lot of work in. Many people will know that I have had a complex knee injury myself, but I'm intending not to talk about that today or to quiz you on that at all. So before we start, I was wondering if you could introduce yourself, maybe tell us a little bit about who you are and the kind of work that you get up to.
Okay, so I'm a physiotherapist by profession. I have two main jobs. My wife's also a physiotherapist, and we set up a clinic about 10 years ago. That's in Moster Hill, South Liverpool. It's called the Physiotherapy Centre. And I'll just see patients there, really. I'll do some training and stuff like that. And part of my private work, I'll deliver a course on assessment and management of knee injuries. I'll do that at the clinic, but I'll do it at different clinics as well. So primarily, I'm clinical. But the majority of my hours are actually spent in the NHS. So I work in North Liverpool, so Aintree, near the racecourse, which everyone knows where that is. I work as an ESP in lower limbs, predominantly knees, but I do some hips as well. So again, my work is primarily clinical. I do some research as well, but I'm at the coalface assessing and treating patients.
That's good. Now, I read that you were a professional football player. Is that right?
Kind of, yeah. Officially, yes. Not that I played that much, yeah. Well, probably it's a similar scenario to yourself. So I had a problem with my knee. So I had osteochondritis when I was young. We were in a training session. I was at crew, which is quite topical at the minute, but we were doing aerobics of all things, and I twisted, and the kind of fragment kind of came out. So that put an end to my football career. So I had a contract for 3 years. And I think this happened about maybe 6 months into the contract. So I spent the rest of the time having treatment and trying to rehab myself. At the time, it wasn't a really, pardon me, a well kind of, I wouldn't say a well-known injury, but they didn't know how to manage it very well. So the surgery that I had was pioneering. So we were winging it. When could I run? When could I do this? When could I do that? So I think after, I think it was about a year and a half, 2 years, we decided that there's a good chance I wouldn't be able to play professional football. So I went to university, did physiotherapy on the back of that. And that's probably why I have a special interest in these as well. And then I played semi-professional while I was doing my physio degree, and I did that for a few years. So yeah, officially I was, but I never really played as much as I should have.
So I wanted to ask you about that because that must be where your interest in the knees come from, and obviously footballers have a lot of complex knee injuries, so I'm imagining that you see lots of those. Um, so let's start by, if I can ask, what would you define as a complex knee injury?
I would say, any injury can be complex because there's serious pathologies that can happen even with what you would class as more simple knee injuries. But I think when we're talking about multi-ligament knee injuries, by definition, we're talking about injuries that happen to more than one ligament. So you've got your cruciate ligaments. Obviously, there's two of them, the anterior, posterior. You've got your medial and your lateral knee. Now, some people think it's just the MCL and the LCL, but there's a few more structures going on around there. So you've got your posterior oblique ligament, which kind of comes off the back. The medial collateral ligament itself has two different bits. There's the superficial and the deep part. You've got your lateral knee, which is your lateral collateral, your popliteus and popliteal fibular ligament, and them together would make up the posterolateral corner. And then obviously you've got your patellofemoral joint as well. So that has a tendency to dislocate laterally. So the medial patellar tissues, especially the medial patellofemoral ligament, that would usually get injured as the patella goes out. So any combination of them really, so kind of two or more. But when you get these injuries, probably 50% of the time, thereabouts, you'll have meniscal injury or you'll have chondral injury, which I know you spoke about before with your knee. So I think I would class them as complex knee injuries because if there's more than one structure that's involved. But even within those two structures, the complex bit with assessing is that you could have an ACL and a medial collateral ligament injury, which would be classed as a multi-ligament knee injury, but you could have a grade 1 or a grade 2 or even a grade 3 MCL injury with an ACL, and you can treat them all very differently. So if you had, say, an avulsion of your medial collateral ligament, so it kind of comes off the tibia, so it's called a steno-like lesion, you would treat that very differently to if you had a grade 2 or grade 3 mid-substance MCL. So my definition of a complex injury would be more than one ligament.
Okay. And I think as you talk about all those ligaments, maybe some of us focus in on just the main four that we all know about: ACL, PCL, MCL, and LCL. And there are lots more, aren't there, around that we need to consider. And so, as a clinician, when that person comes into the clinic and you know there's a ligament injury, um, when do you know? How do you assess to see how much injury there is? Let's say so. Do you know what I mean? It's just
Yeah, I think it depends on the setting. So if you're sat in a clinic and the person's maybe come in through A&E or they've seen a GP or whatever, I think they're very different animals to those that if you're, say, a football physio or a rugby physio, where you run onto the pitch and you see the person as they actually do it. So I'll talk about it from a clinical perspective. So I think the first thing would be the history for definite. And I think if you do teaching, especially with doctors, they want to just dive into the objective tests. They want the fun bits. They don't want to do the boring talky bits. But I'll give you an example of a patient that I saw, I think it was last week, who'd come in and they'd been sent to me in physiotherapy. They'd been into clinic. I had no information because they'd only been in the week before and the clinic that hadn't been typed up. So before the patient came in, I'd seen that they'd had an MRI scan. So I looked on the kind of clinical information. It said query meniscus tear. So I thought, well, this can't be that kind of severe an injury. And then when I looked at the scan myself and then checked the report, the ACL had gone, the PCL, lateral, collateral, post-lateral corner. So straight away you think, this person's had a nasty injury. And when they came in, the first question was, how did you do it? And he came off a motorbike at 30 mile an hour, having been hit by a car. So you think, if it was just a meniscus injury, that would be like a miracle, for him to just have had that. So I think the first thing to think about is, how did they injure it? Was it a high velocity injury? So, were they hit by a car? Did they fall off a roof? Was it a low velocity injury, which are more like sporting injuries? So even though you can have severe injury, they're classed as low velocity. And there is also a separate category, ultra low velocity. They tend to be more obese patients that injure themselves in activities of daily living. So they might just fall from a normal height or fall off the bed or something, and they can have severe injuries. So I'd kind of really probe them on how they did it. Did their knee pop out at the time? Those type of questions. More often than not, patients will say the knee popped out and it was their kneecap. But sometimes it's actually their knee, it's the tibiofemoral joint. And in a weird way, it actually works to our advantage if the patient hasn't had the knee pop back in for them until they get to A&E, because you can x-ray them and say, no, it was your kneecap that came out, or it was your knee. But more often than not, a paramedic or the patient will have popped the knee back in, and then it becomes a bit more complex. If the patient has a history of hemarthrosis, so swelling within the knee joint within a few hours or very quick, that to me would suggest there's something serious going on. And there was a paper that came out, I think it was this year actually, from Olsen. I think it was Swedish patients that went to A&E, and all the patients that had hemarthrosis were MRI scanned. Now, MRI scans are not 100% foolproof, and there's some issues with that. But they found that most people had quite severe injury. So I think more than 50% had an ACL. But what was quite surprising, well, not surprising, but quite interesting, was the fact that very rarely did they have injuries on their own. So lateral patellar dislocations were probably the exception to the rule. So 65% of people just dislocated their kneecap and nothing else, whereas ACLs, only 12% of them happened on their own. So with a traumatic hemarthrosis, you'd be thinking, right, something probably serious is going on here. And obviously the history of instability as well. So the patient would usually say, I don't trust my knee, it's giving way, it's collapsing. So before you've even laid your hands on them, you've got a suspicion that something a bit more sinister or severe is going on.
So thinking about that patient that comes into the clinic and you ask them you talk in the subjective, you're thinking through the questioning that you've done, you're thinking, oh, maybe there's something serious going on here. When do you decide to send for imaging or MRI?
Well, the first thing I do is just check if they've had an x-ray first, because sometimes, believe it or not, they should have had an x-ray and they haven't. So I check that first. But I think in terms of MRIing, I tend to work on the basis that if I think it's going to change my management, because it's reassuring to get MRI scans. But if you assess the patient, you're pretty confident they've got whatever, ACL plus, the lateral, collateral, post-lateral corner's gone. you can send them for imaging, but it may not change your management. So those type of patients would usually do better with surgery. But some of the surgeons that I work with like to have that imaging first, just so there's fewer surprises. You know, if they do go in there to have surgery, you've got that information. Some of the surgeons I work with as well, from a medical legal perspective, like that imaging as well. Again, just in case the patient has a bit of a moan about it further down the track or there's a complication. But I think the definite group that I would send for an MRI scan straight away would be those that have a locked knee. So if the person sat in front of you and they can't physically straighten their leg, or you can't physically straighten their leg, I would send them for an MRI scan pretty quick to see what it is that potentially is stuck in the joint. Now, it's funny actually recently, because more often than not, it's bucket handle tears of the meniscus. That's the thing that's kind of stuck in the joint. Or they might have an osteochondral lesion that's kind of come away, like what happened to my knee when I played football. But a lot of the time, the meniscus is absolutely fine. And it might be that they've got an isolated ACL rupture. And there's a paper come out, I think it was Carmont, who suggested there's a thing called a stump impingement reflex. So if you rupture your ACL and then you pinch the ACL, then your hamstrings kick in, so it prevents your leg from straightening. And more often than not, if that's the case, if it's just the ACL, by the time they come back in to see you after their scan, the leg's straightened out. But sometimes there's absolutely nothing wrong with the knee. But because you can't really leave them with a bent knee, I'd send them for a scan and try and figure out what's going on. I think it has to change your management really. Otherwise, it's a bit of a waste of, I wouldn't say a waste of money, but you know, it's expensive to get scanned, and it just delays things really.
Mm. So I know I'm jumping ahead a little bit now, but you talked about surgery, and instead of sending for MRI, those patients that you are suspecting of being quite complicated, you would send for surgery. So I'm going to come back to things that we should probably already have talked about, like the objective and things. But because you've mentioned surgery, when would you send for surgery? Because we're looking at that patient in front of us. So we'll only send for MRI if we think it's going to change our management or if there's the locked knee. When would you then decide to refer on to the surgical team or onto someone else?
Yeah, so the problem with kind of multi-ligament knee injuries and knee dislocations and things like that, they don't happen that often. And some of the kind of statistics I've seen is they account for about less than 0.02% of orthopedic injuries. So you're not going to have them kind of streaming through the door. So there's not a lot of research or good research that's actually been done because it doesn't really lend itself to like prospective randomized controlled trials. But the evidence that's out there at the minute, albeit kind of limited methodological quality, would suggest that multi-ligament knee injuries do better with surgery in terms of function, return to work, return to sports, stability, those type of things, than if you manage them conservatively. So again, the main consultant I work with is a guy called Mike McNicholas. He specializes in multi-ligament injuries, soft tissue reconstructions. And I've worked with him for a long period of time, and kind of he would agree with that. And we tend to send those patients on that have multi-ligament knee injuries to surgery straight away. I think there's one grey area for me, and that would be probably close to your heart as well, the ACL and the medial collateral ligament knee injuries. Because if you split them up individually, we know that if you've just got an ACL on its own, from the Cannon trial, the Froebel papers, 2010, 2013, that about 50% of people can cope without their ACL. So they can function normal, they can play sports, and they can do just as well as those that have surgery. And medial collateral ligament or medial knee injuries on their own, they can heal. So if you've got that combination of injury, if the medial knee heals, so you have nice valgus stability and there's no increase in rotational instability, in effect, you're then left with an ACL rupture on its own, so an isolated ACL. So I tend with those patients to see how they get on. So even though it's a multi-ligament knee injury, it was two and then it becomes one because one's healed. There are some studies out there saying that people can cope with combined ACL, medial collateral ligament knee injuries. About 70% of them can return to contact sports and normal function. The people that tend to do worse are the older people or the more sedentary people. But the high quality studies in that area, the randomized controlled trials, what they've done is they've reconstructed the ACL early and then either reconstructed the medial collateral or left it alone. And there was no benefit from surgery to the medial collateral ligament over just managing it normally, but the ACL was reconstructed, you see. So it's a bit of a grey area for me, because there's research saying that they do well with early reconstruction, but there's also research saying you can leave them alone and some people can cope. So that would be the area that I'd think, right, I'm going to leave this patient a little bit longer. If it's an ACL, MCL, see if the MCL heals up and see if they can cope without their ACL.
So to kind of summarize what we've been saying, or what you've been saying, ACL, MCL is more common than other ligament combinations, I guess. And we're saying that's like a grey area. So that's the grey area in the middle. Anything more than that, we should be considering sending on for another opinion. And anything less than that, we should perhaps be managing ourselves. Would that be fair to say?
I think that's a fair summary. Yeah, I mean, one of the consultants I used to work with used a really good analogy. He said that if you've got a chair with 4 legs, and the legs represent the ligaments of your knee, and if you're stood on that chair and all the 4 legs are intact, you can stand there, you can balance, you're not going to fall over. If you lose one of the legs of the chair, which represents one ligament injury, if your balance and coordination is good enough, you might be able to cope. But if you take any 2 legs off the chair, it doesn't matter if it's the front 2 or the back 2. The person's going to struggle, for stability wise. So yeah, that's a nice analogy to think of, but it just depends whether you can repair that leg of the chair, which would be your medial collateral ligament. But yeah, I think that's a fair summary of.
That's a really nice analogy, actually. That's very easy to remember. Okay, so jumping back to objective, we talked about subjective. Subjective is really important to know about the mechanism of injury, and obviously how well, not necessarily how violent, but we need to know what happened so that we can have an indication of what might be injured. Let's talk about objective. What are the tests that we can use, that we can reliably use in the objective assessment to confirm our sort of subjective hypotheses?
I think that the reliable ones, or the valid test, there's one that stands out, and that would be Lachman test ACLs. That's the one that seemed to have stood the test of time in terms of being very good at ruling in an ACL rupture or ruling out an ACL rupture, whether it's kind of positive or negative. The problem is all the other ligament tests, you do them and you use them clinically, but some of them have very limited evidence behind them. So the first test I would use would be to check for intra-articular swelling.
Which one, sorry?
The first test, I'd want to see if there's any intra-articular swelling, so effusion, or it depends how quickly you see them. Whether if it's within a few days, whether it's swollen and there's a history of it happening straight away, that would indicate probably bleeding. So in fact, just kind of to go off on a little bit of a tangent, the patients that I see that come in from A&E who have an immediate swelling in their knee, we're doing a study at the minute on ACL stem cells, or stem cells for ACL reconstruction. So I would aspirate the person's knee. So I'd take the blood off their knee. So if I see that there's blood on their knee, I know that there's probably more of a severe injury going on. But if the swelling was more gradual, so maybe that night, the following day, you'd be probably thinking less of a severe injury. But I'd want to check there's the swelling within the knee joint, and that would probably indicate there's something inside the knee joint is going on. So I'd do that. The other thing I'd check for, I think when people check for range of movement, they're checking to see whether the knee's locked. And that is definitely important, as I mentioned before. But another nice test to do is to check whether they've got excessive amounts of movement in the knee. So if you extend somebody's leg and it's extending more than the opposite side, so kind of like almost like a bird's leg, it's bending backwards. If you do that but grab the big toe, so you're pulling from the big toe, that's called the external rotation recurvatum test. And they used to think it was suggestive of combined PCL posterolateral corner injury. But Robert Laprade, who's an American surgeon, is really famous and does lots of kind of research studies. They revisited that test a few years ago. I think it was 2008, 2009, and they found that it was more indicative of a combined ACL posterolateral corner injury. So the sensitivity of that is around about 30%, and the specificity is 100, according to them. So if you get this positive external rotation recurvatum test, it's highly suspicious of a combined ACL posterolateral corner injury. It's quite a simple test to do. You just fix the femur, pull up from the big toe, and see if it moves further than the other side. So it's not difficult to do. And then the other tests I'd do, I personally look at the structures individually, but there are some tests that you can do that look for combined injuries. So I do my varus and valgus stress test at 20 or 30 degrees. Even though that's probably one of the most common tests we do, there's limited evidence behind that, in the research of how valid or kind of reliable the tests are. So from a medial collateral ligament perspective, if you look at the work of Laprade, and I think I can't pronounce it, but Wijix, I think it's like a Dutch name, they would suggest that if you do valgus stress at 20, 30 degrees of knee flexion and the legs opening up, so if you've got a hard end point but it's opening, that would be a grade 2. If there's opening up but no end point, that would be a grade 3. If you then do it at 0 degrees of knee extension, and it's nice and stable, then that little ligament around the back, what I was talking about before, the posterior oblique ligament, is likely intact. But if it's opening up at 0 degrees, that's probably gone as well. So you've got like a whole medial knee injury, and there's about an 80% chance that your ACL is gone as well. So I do the same on the lateral side. Sorry, I'm giving you loads of information there. Do you want to talk about that? Any more detail? The one probably to be wary of is for ACLs is pivot shift. Because for pivot, if you've got an isolated ACL injury, if you pivot shift somebody and it's positive, they've pretty much got an ACL rupture. But for that test to work, the medial knee has to be intact and also the iliotibial band. So if you've got an ACL medial knee injury, you can't really do the pivot shift.
It's also, people really protect from the pivot shift, don't they?
Yeah, absolutely, yeah. Because in effect, what you're doing is you're subluxing the person's knee and then you're trying to pop it back in. And people just won't, well, they do let you do it. You've almost got to catch them by surprise. My recommendation is don't do it on the good leg first because they know what's coming. So try and catch them by surprise. But I think if you get a positive pivot shift, the person usually would say, oh, that's it, that's how my knee went. It kind of replicated the way they injured it in the first place. So it's a good test if you get a positive, but the sensitivity is really low. I think it's about 30, low 30s. So which means that if you do the test and it's negative, you can't really say with confidence that they haven't got an ACL rupture. It's only really good to rule it in. What other tests we got? The posterior cruciate ligament. So there's only one systematic review that's been done on posterior cruciate ligament. That was by Christian Kopkow. That was out a few years ago. And from their review, they found the best tests were the sag sign. So you basically lie the person on their back. The hips are flexed to 45 degrees, knees at 90 degrees, and you're seeing whether the tibia is kind of sat backwards. And for me, they're quite obvious. They've got like a banana shape of the tibia, kind of instead of kind of sitting a little bit forward, it's just dropped right back. And then an extension of that test would be the quads active test. So you put your hands around their ankle, they try and extend their knee. So they're used basically contracting their quads. And then the quads would then kind of reduce their knee. They'd put it back into the position that it should be. And my favorite, the posterior draw. So I think, again, when I'm teaching, I say to people, if you're in the posterior draw position, gravity is trying to take your leg backwards like this. So if you just push down further, it's probably taking up any slack that's in the tissues. So I make sure that people pull their leg forward first, then drop it backwards down, see if there's more movement. And it's nice in that you can feel a nice end point. It's like the Lachman test. You can feel, is there something stopping the movement or is there not? And then the one other test I do for individual structures would be the prone dial test. Mm-hmm. So you lay the person face down, you kind of grab the ankles and you have the knee about 30 degrees of knee flexion, and then you rotate the feet outwards, trying to make sure the movement comes from the tibia rather than the feet. And if there's greater than 10 to 15 degrees difference in rotation between sides, so the injured side rotates more, then that would be suggestive of maybe of posterolateral corner injury. If it's negative at 90 degrees, that is. If it's also positive at 90 degrees, that's when it gets a bit tricky, because that could be indicative of a combined posterolateral corner injury plus a PCL injury, or it could just be a medial knee injury. So again, you're getting rotation from your leg, but is it coming from here or is it coming from here? It's like your leg can rotate from two different areas. So almost if you see someone, they've got a positive prone dial test at 30 but negative at 90, you kind of wipe your brow and think, great, this is probably more of a posterolateral corner injury. I don't have to look into any more detail. But they would be individual structures. There's a few other tests that you can do which are more for combined injuries. So I've already said about the external rotation recurvatum test. You've also got your posterolateral and posterolateral and anteromedial draw test. So it sounds quite complex, but it's dead simple. You get the person in like an anterior draw position, but then you rotate their tibia laterally, so about 10, 15 degrees. And you push the leg backwards, but also try and get some external rotation. That's for the posterolateral draw test, and that's usually indicative of a combined PCL posterolateral corner injury. And you can do the anteromedial, which is pulling forwards and externally rotating, and that could be a medial knee injury plus or minus an ACL. But they would be the main ones. There's all sorts of weird and wonderful ones, like reverse pivot shift and stuff, but they would be the ones that I would use as my staple tests that I use on everybody. And then it's trying to interpret the kind of the test. Once you get your head around, it's quite easy, but it's quite difficult to start off with.
Yeah, so I'm sitting here smiling at you because I just know that everyone listening to this now will be, oh, I wish I had all that knowledge in my own head. So what I would suggest if I was, I don't practice anymore, but if I was practicing, I would listen to all that you've just said about those tests, and I would probably write down, just make a note of everything that you've just said, list the test and how to do it and what its indication is. I think, so if you are listening to this, I would just go back 5 minutes and listen to that again and write that down so that you have that on record for yourself, because that's amazing knowledge to have at your disposal in your head, I think, to be able to do these assessments.
It probably sounds quite complicated as well, but it's not. Once you do if you actually demonstrate the test, people go, oh, was that it? It sounds quite good, but it's not that difficult. I think the thing to take into account, like anything, is that there's always, none of the tests are 100%, kind of foolproof. Some of the tests don't even have evidence behind them, like the dial test. Clinically, when you perform it tends to correspond well with them having posterolateral corner injuries and stuff. And again, Mike Miniculis, the guy who I work with, I had a discussion about it, and he said that of all the patients that he sees that have a positive dial test, when he then goes to see them in surgery, he's had like one patient, I think, out of the hundreds that he's done that didn't have a posterolateral corner injury. So it is probably an accurate test, if you like, but just hasn't been researched. So I'm telling you from clinical experience or kind of like expert opinion, but you have to realize that you do these tests and sometimes they work and sometimes they don't, but these are probably the best tests to try anyway and see how you get on, and put it together with your subjective history as well.
Exactly, match it with that subjective, and it's always a combination of tests as well. So there isn't one test that's going to give you an answer, is there? It's a combination of tests that'll fill in the picture for you.
Yeah, exactly. It's almost like a process of elimination. So if you see the person, I tend to go through the same tests every time, and if by the end of it all the tests are negative, then I'm pretty happy to say to the patient, listen, you've injured your knee. Yeah, I don't doubt that. And it hurts, but structurally it seems like everything's intact. Therefore, it should heal. It should kind of resolve itself. And I suppose that's like a bit of psychology in there as well. The patient walks out thinking, oh, this is good. It should get better. But I think if you do, say, for instance, the external rotation recurvatum test, which is ACL posterolateral corner or maybe PCL posterolateral corner, I'd really want to test them structures individually and go, am I happy that they're actually intact or have they gone? And sometimes it doesn't work out. It'd be nice if you then did their individual tests and it confirmed it. Sometimes they're fine. And you think, okay, maybe it was just lying to me, that test on this occasion. So
yeah. Okay, now before we move on to any management aspects, what about red flags? Are there any red flags that we should look out for in these kind of injuries?
Yeah, so there's a nice section on the Clinical Knowledge Summaries website, which is from NICE. It's not a NICE guideline, it's just a website. And they describe the main red flags for traumatic knee injuries as penetrating injuries, infection, neurovascular injuries, bleeding disorders, deformity, and gross instability. So I think out of those ones, assuming the person hasn't had a penetrating injury and therefore isn't going to get an infection, the one that I'd really, really, really look out for is the neurovascular injury bit. And again, for me, because I see patients after they've been to A&E or after they've seen a consultant or after they've seen a GP, chances are I don't really see them, because if they had a neurovascular injury, they probably would have either died by that stage or kind of lost their limb, or someone else would have picked them up. But again, if you're a run-on physio that goes onto a football pitch or a rugby team, it's that vascular injury. That's the really, really important bit. And again, just some statistics kind of read through before we did this interview. With knee dislocations or multi-ligament knee injuries where the knee can pop out, about 18% of them can have a vascular injury. Of those 18%, 80% go on to have vascular surgery. And of those 80%, 12% lose their limb. So they have an amputation. So again, we were talking before, they don't happen that often, but when they do happen, they can be quite severe kind of consequences of that. So so again, I put myself in the position of a sports physio. I don't do that, but the things that a nice mnemonic to think about is the 5 Ps for vascular injury. That would be pain that's out of proportion to what you would expect for the injury, pins and needles, paralysis, so the motor component to it, because the nerves aren't getting their blood supply. They get like sensory or motor deficits. Pallor, which is like a pale appearance of your leg, so discoloration, or any discoloration for that matter. It might go a bit blue or whatever. And pulselessness. So you check the pulses, dorsalis pedis and posterior tibial pulses, and see if they're symmetrical, or are they weaker, or are they absent. And you can do the popliteal artery or the popliteal pulse, but sometimes with a knee injury, there's lots of swelling around there, so you can't really feel it. Or the other one probably would be an expanding hematoma in that popliteal fossa, so it's basically bleeding out. So they would definitely be red flags for me for arterial injury. The other one, which involves the blood vessels, but it's slightly different, is acute extremity compartment syndrome. So you can get a chronic exertional compartment syndrome, which is slightly different. But in the acute setting, especially in things like fracture dislocations of the knee, you can get this kind of buildup of swelling and blood in the compartments of the leg. It happens in about 30% of cases. It's just the soft tissues that are injured. There's no fracture. So without going into it in too much detail, supposedly after the injury, the venous outflow is reduced, but the arterial inflow is normal. You can get bleeding, you can get swelling developing. And then the pressures within separate compartments of your knee build up. If the pressure gets to the point that it's greater than capillary pressure, then any tissues that are supplied by those capillaries don't get their blood supply because the capillaries are choked. So the earlier signs, again, are pain that's out of proportion, but you might get some pins and needles, but apparently motor nerves have a bit more resistance to ischemia. So you might not get that motor bit, the paralysis early on. And you should only really get pallor and pulselessness if the pressure gets above systolic pressure and it kind of chokes off the arteries. So if your blood pressure is 110/70, then it should only be when it gets to 110 or more millimeters of mercury. So you might not get the pallor and the pulselessness, or if you do, it's in the very late stages, and by which stage you've probably got irreversible muscle and nerve damage. So similar presentations, but different, if that makes sense. But again, the one probably big red flag is pain that's out of proportion. You think, is there some sort of arterial injury or some sort of compartment syndrome? And you've got to get them off your caseload. You've got to get them to a medic. You've got to get them to somebody else, because there is that risk that they might lose their leg, or they might get an infection that spreads elsewhere. It triggers sepsis and the person dies. And you don't want to have to defend yourself. And why didn't you do this? Why didn't you do that? So just make sure that you kind of appreciate your boundaries and know that it's not a physio thing, that we don't treat it with physiotherapy. We get the medics involved. They would be the main red flags, I think, that I'd be looking out for.
And so that pain that's out of proportion, I'm going to say that's fairly easy to identify, because ligament injuries don't necessarily cause that much pain, do they?
I think in my experience, I've never had one myself. You could probably answer that question better than me, but most people, when you ask them when they injured it, they did get a lot of pain at the time of the injury. But once the knee settles, a few days later, pain's not their main problem, it's instability. But if you've injured it at the time, then they might be in a lot of pain. But yeah, I saw a guy on Monday who was 3 months down the track from a knee dislocation. And again, I always make a point of asking the patients this when they come in, because he said at the time he got taken off the pitch and his pulses were reduced and his foot was discolored and stuff. And I made a point and said, what was your pain like? And he just went, it was just so intense. Like, I never had anything like it, And the patients that I do ask, they will say that it was ridiculously painful. But I mean, it's difficult, isn't it? Because if you break your leg, and sometimes you get fractures involved in these injuries, it is going to be sore. But probably pain that's out of proportion, pain that's not responding to medication the way that you would expect it to, pain at rest, with compartment syndrome, stretching the separate compartments as well might make the pain come on a little bit more. But yeah, you could probably answer that question better than me because you had the knee ligament injuries yourself.
Yeah,
So
I guess that's why. Yeah, I didn't have any pain, so yeah, I guess that's why I said it. Yeah.
yeah.
Okay. Good things to look out for, definitely. So we've kind of covered when we would refer on to another, to the surgeons or the orthopedic team. So we've talked about the red flags and the vascular injuries, and we also talked about more than two ligament injuries, definitely. Bit of a grey area with two ligament injuries. So once we've referred those people on, they're not our concern until they come back after their surgery.
Yeah.
So the people that we keep, and this is a huge question. Let's talk about management, and obviously it depends what they've done. But are there any sort of general management tips that you can give to people?
So is this, sorry, before surgery or is
Before, yeah,
before?
conservative management.
Yeah. So we would tend, again, this is where it is tricky because there's no kind of consensus. Everyone does things differently. We tend to put people that have posterior cruciate ligament injuries into some sort of like posterior tibial support braces, unless they've got an ACL injury as well, because then you're just kind of forcing the tibia real forwards because it hasn't got that restraint. So if it's say like a PCL medial knee, PCL posterolateral corner, we would put them in either a jack brace or a rebound brace. So I don't know if you're familiar with them, but the jack brace, I think the paper came out in 2010, and it's the only clinically validated brace that's out there. So it was in people that just had PCL injuries. So we're taking that information and applying it to other people as well, even though there's no evidence as such. Because the posterior cruciate ligament has this intrinsic ability to heal. It's just how short it heals or how tight it heals. So we would put them in those braces. The rebound brace is slightly different in that the more you bend your knee, the more stress goes on your posterior cruciate ligament. So the rebound brace replicates the loading profile of the PCL a little bit more. So as you bend your knee, the brace gives you more and more support, which the jack brace doesn't. The problem with the rebound brace is it's twice the price. You're talking like £300-400 for a jack brace and £700-800 for a rebound brace. And our appliance officers kind of when these braces first came out, they said, yeah, send them around, no problems, we'll get them a brace. And then after the first one or two, they were like, hang on, we don't want to pay for this. But the patients that we have seen, in our experience, they tend to, I wouldn't say enjoy it more, but it's more comfortable for them than the jack brace. But the jack brace does a good job clinically. If you've got a medial or lateral knee injury with an ACL, we would tend to put them in a brace. So if you look at, say, the medial knee injuries on their own, there's one systematic review saying that if you brace them or you don't brace them, it doesn't really matter if it's just a medial knee injury. In our experience from our audit data, people who you don't put in braces tend to have that kind of persistent instability more than those that you do stick in a brace. So whether it slows them down or not, I'm not quite sure. But the research that's been done in combined injuries tends to use braces. So we'd put them in that. And then I think the general principles of any injury is get the swelling and the effusion down as quickly as you can. Try and get the range of movement back as quickly as you can. Restore muscle function and strength, because again, we're taking this more from, say, the ACL literature, is that the stronger your leg is before you have surgery, the better you tend to do afterwards, or the quicker you tend to recover, and the fewer complications there tends to be. But just mentally preparing the person for surgery as well, because it's not just a physical thing. This is how long you're going to be out for. This is how long you'll be on crutches for. This is when you can start climbing ladders. This is when you can start driving, etc., etc. So that after surgery, they're ready to go. And they've done their exercises, they're familiar with them, and they just pick it up easier afterwards, I think. They would be the main kind of rehab tips. It's such a topic, isn't it? But that I would suggest.
Yeah, and that just echoes our physiotherapy skill, doesn't it? That's what we do. All those things. Yeah, and I think any physiotherapist should be able to just take on board those, use their skills to do exactly what you've just said. Bring the effusion down, get the strength back, all those sorts of things.
Yeah.
And obviously, and I know people always ask us, well, give us the exercises that we need to do. And you can't do that, can you, there are no specific exercises that you can prescribe for each injury because it depends on the person and the injury and what their deficiencies are and how they were before they injured themselves. So there are no so I would not ask you to describe specific
Yeah.
exercises for
Yeah. I
people
mean,
who I know would ask that.
yeah, I mean, I would favour it if it was at all possible. And bear in mind, people who dislocate their knees or have these multi-ligament knee injuries, they tend to be in their 30s and they tend to be males. So there's probably more likelihood they'll be gym members than say like an 80-year-old male. You know, they've got this kind of gym access, and I really favour kind of getting them on machinery and kind of lifting heavy weights beforehand. But you're right, some people just either don't like the gym, can't afford the gym, don't have a gym membership. So you're trying to give them stuff that they can do in their own home with minimal equipment, and trying to push them as much as you physically can, and trusting that they're actually going to do it as well. And there's so much psychology in that as well, you know, kind of trying to, you know, kind of plead with the patient to do what you're asking them to do. But yeah, I agree. And to a certain degree, I think with the one that I would say that if you have posterior cruciate ligament injuries, probably more so if you're managing them on their own, so if they're isolated injuries, is to really go for quads work rather than hamstrings, because your hamstrings, if anything, is going to translate your tibia backwards. So you want to give that posterior cruciate ligament a bit of a rest. You know, don't stress it too much. Give it a chance to shorten. But the other ligament injuries like ACLs, if it's ruptured, it's not going to heal. So you can just kind of blast the leg as much as you like. Medial collateral ligament injuries tend to kind of respond or heal quicker with some nice gentle stimulus pretty much straight away. So bike work and stuff like that as soon as you can, as long as they can get 9,500 degrees of knee flexion, they can get on the bike. And if you look at the work of Laprade and his group again, he's a big surgeon for post-lateral corner injuries, he will say that post-lateral corner injuries don't heal because the lateral aspect of the knee, it's inherently unstable. You've got like a convex on a convex bone, so it's more wobbly than the inside part of your knee. So again, you're not really trying to allow that area to heal. You're just kind of working the knee as much as you can to get it nice and strong.
Okay. Is there any different advice for the patients that come, or any different management options for the patients that come back to us after their surgery, or is it exactly the same as all that we've just talked about?
I think again, this is the tricky bit because it's usually protocol driven and it's usually agreed with the surgeon. So every surgeon will have totally different protocols. Some will weight bear them earlier than others. Some will kind of weight bear them further down the track. We tend to limit with multi-ligament injuries. We tend to limit weight bearing for 6 weeks. We go non-weight bearing for 6 weeks, just allow the area to kind of settle, and then we partial weight bear them for another 6 weeks or so, and then you wean them off the crutches. They've all got braces on as well. So again, with your posterior cruciate ligament involvement, they've got this jack brace or the rebound brace. You wean them off the brace from 12 weeks plus. Sometimes patients can come off crutches but stay on the brace. But some like to take the brace off and stay on the crutches for a little bit longer. But the PCL injuries, you've got to leave the brace on for about 6 months if you want to do the job properly, or if you look through the kind of the research behind that. Yeah, weight bearing is definitely something that you'd slow the person down on. Again, talking about posterior cruciate ligament injuries, avoiding too deep a knee flexion for a while to give that area a little bit of time to relax. To heal, avoiding isolated hamstring injuries till about 4 months. With your post-lateral corner injuries, trying to avoid external rotation or excessive external rotation for 4 months. And you're looking maybe getting them probably jogging around about that stage as well, maybe 3-4 months down the track. But yeah, the prehab and the post-operative rehabilitation is very similar. And that's why it's good to do it beforehand as well, because you're just preparing it. This is what you're going to be doing afterwards. But again, the other thing, it's such a heterogeneous group, is that you could have these ligament injuries with a fracture as well. You're limited by the healing of the fracture. So it is really tricky. You could probably be here all day long, but our protocols are on, if anyone wants to look at them, again, the guy who I mainly work with, Mike McNicholas, he's got a website, nicholaskneeclinic.co.uk, I think. And all our protocols are on there. It's there for patients, but also practitioners. And it just strips down the kind of the rehab in kind of like 2, 3, 4 week blocks. and tells the person what they can do at certain times. I think what's more important with those type of situations is what to avoid as to what to do. Again, I always think if the surgeon doesn't want you to do that, if you decide to kind of go against that and do it, and then the patient has a problem, you put yourself in the firing line for getting shouted at. So
Yeah, for sure.
it was a protocol, just follow it.
Okay, all good advice. I think we've covered a lot there. Is there anything that we haven't covered or I haven't asked you about that you think we should talk about?
Not that I can think of really. I think they're the main areas. No, I think that's pretty much it.
Yeah, I think you've covered it here an awful lot in so much detail, which is an amazing help for people to take. You know, what you've talked about are things that people can actually just take into their clinical practice now, having listened to you.
Yeah.
There are a couple of things I would add. One, I meant to say this earlier. When you're aspirating the knee, you're trained to do that.
Oh yes.
So I would.
Funny enough, though, this is a grey area as well, because even things like injections, as far as I'm aware, unless it's changed since I injected the knee, you don't need an official qualification to be able to inject people's knees, as long as you've been shown how to do it by somebody properly. So if something does go wrong, you've got that evidence. But my advice would definitely to be get that training done. And I mean, aspirating knees, most people do injections so they can stick, drugs into people's knees and make them feel better. But I actually find personally now that aspirating people's knees is probably more, or arguably as useful, maybe even more. So if you have somebody that comes in with a big swollen knee with no injury and you're thinking, is it infected or is there gout or whatever? You stick a needle and you draw that fluid out and you send it away and they'll give you the answer. But I mean, you could argue with traumatic hemarthrosis. The hemarthrosis will settle in a period of time. When you drain the blood off somebody's knee, they do tend to feel better. So it's giving them kind of, symptom relief straight away. But again, we're doing this as part of a study that's, had ethics approval and stuff as well. But yeah, I kind of at least know how to do it. I wouldn't just kind of go practicing on patients.
No, I would add, if you're not trained to do this, don't do this at home in your clinic, or just find someone that is trained to do it for you. And then if you don't have anyone that's trained to do it, it's not necessary as well. So, and then the other thing I would just add is that about braces, because not everybody has access to braces in their clinics. They're not necessary either. It's possible to totally rehabilitate a knee without braces, isn't it?
Yeah, I think for definite things like ACLs on their own, there's no benefit of using a brace. I think for posterior cruciate ligaments, if you didn't have a brace, if it was an isolated posterior cruciate ligament and you're trying to get that ligament to heal in as short a position as possible, there's certain things that you definitely want to avoid. So, I mean, if you sat there watching the telly with your leg out straight, that's fine. But if you sat there with your leg bent watching the telly and it's in that sag position, you're encouraging it to heal in a lengthened position. That's where I think the braces help, because you can sit in that position. That's good. So yeah, so if you're sat in front of the telly with your knee in a bent position, the gravity is going to try and take your leg downwards, and this is where the braces probably help, because it just props it forward. So I think if you're not going to use a brace for PCLs, there's just certain things that you'd want to make sure the person avoids, again, to allow that tissue to heal. But yeah, you can almost get away with it, or even like cricket splints. They tend to be a bit cheaper, just holding your leg out straight if you can't access them. With PCL injuries, one of the surgeons I used to work with used a cricket splint with a towel or a pad underneath the tibia. So if anything, it's trying to prop that forward. But yeah, that's the tricky bit, isn't it? Ideally, or not ideally, but some people think that you should use a brace, but it's just whether you've got access to them. Same as gym equipment.
Yeah, definitely. Okay. Have we got to talk about anything else in relation to multi-ligament knee injuries?
Shall I look at my list and see if I put anything else down? I think we've covered most. I mean, we haven't really talked about patellofemoral dislocations. And again, they're probably slightly different because they probably more often happen on their own. The evidence behind kneecap dislocations is again, some of the systematic reviews say that there's less chance of your knee dislocating if you have surgery. So it's about 1 in 1 in 4 would redislocate with surgery, but 1 in 3 if you manage it conservatively. So, 25 versus roughly 33%. But whether you have it operated on or not, you can still have little bits of instability. It doesn't necessarily pop out in about a third of patients. And kind of patient satisfaction and functional outcomes and stuff aren't really different between surgery or not. So I tend to manage them conservatively if they're on their own. But again, if it's part of that kind of multi-ligament injury, the surgeons will tend to do it in one go. Some surgeons will do it in a staged fashion, so they'll do like one ligament at one point and then wait for that to settle down and do a different one. But again, all surgeons are difficult. All surgeons are different. They're difficult as well, but they're all different, have different ways of doing it. But I mean, touching on what you're saying before in terms of there's that much information out there. It's on knees itself, and I mainly deal with knees, and it's difficult enough for me to try and keep on top of everything. So one of my colleagues who I used to work with at Warrington, we're in the process, without treading on Physiopedia's toes, is to do like a knee resource, just kind of get something out there so people, if there's, if they're looking at knees and they want to just kind of touch base with things like that, is to have some form of reference point which kind of they can click on quickly. I think that would be quite useful for people, because I'd be the same with things like shoulders and stuff. Don't see as many anymore, and you're forever trying to trawl through the internet trying to remember what tests to do and stuff, and that's probably why I go onto Physiopedia more than anything else. So.
Good. Well, yeah, that all sounds good. It's definitely good to have resources to refer back to. So all those resources that are out there, it's useful to use them, definitely, especially when they're written by somebody like yourself who is very experienced in the topic. So it's always good when you're looking at a resource online to find the resources that are written by people that we know have the knowledge in that topic area. So I think we've covered everything. It's been an absolute pleasure to talk to you today, Richard. Sharing your knowledge with everyone is going to be really, really useful. People will find this really interesting and like I said before, be able to take it straight into their clinical practice, which is always really, really good when we talk to someone like you. So where online can we find you? You've mentioned your clinic, which is the physiotherapy centre.
Yeah.
You're on Twitter. What's your Twitter handle?
I think my name is @RichNorris00.
Okay, so we can find you on Twitter, and we'll add a link to both of those places, and we'll try and find the knee protocols from your colleague's website that you mentioned as well.
I've also done a few blogs. Some people have read them. I'm sure you're aware of them. Tom Goom and Adam Meekins they're on Twitter as well, and they've got some blogs, and I've written some blogs for them. So it kind of covers bits of what we've talked about today. So if you want to, sit down or people want to sit down and read it in their own time and digest it a little bit slower, there's some information on there as well.
Okay, we'll look those up and we'll add those links as well. Brilliant. So, Richard, it's been an absolute pleasure to talk to you today. Thank you for your time. Thank you for talking to us.
Thank you very much.